Welcome to Part 3 of our presentation on the implications for medical practices of the Patient Protection and Affordable Care Act. In this series, we have reviewed some of the major provisions of the Affordable Care Act and how they affect various components of our healthcare system, especially how they affect medical practices. In Part 3, we focus on specific ways the Affordable Care Act affects medical practices. My name is Jim Hook, and I'm the Director of Consulting Services at the Fox Group. Among the many provisions of the ACA are those affecting payment for new patient benefits. The lifetime benefit limits for policies for children were eliminated in 2010. The annual benefit limits for everyone with a qualified plan coverage will be eliminated in 2014. And there are no copays or deductibles for preventive services offered by new qualified plans. These include traditional services such as mammograms and pap smears, blood pressure screening, cholesterol level screening, and colorectal cancer screening. But they also include new screenings for HIV, for depression, for tobacco use, for osteoporosis, and many others. This means the health insurance plan or insurance company will be paying more to the provider, and providers will be collecting less from patients for these benefits. Medicare reimbursement will also change for various types of medical practices. For diagnostic imaging procedures performed at the same time, the technical component of reimbursement will be reduced from 50% for subsequent procedures to 25%. Specific preventive services, for instance the new to Medicare exam, will be paid at 100% of the Medicare allowable for that service. And the incentive for 2011 for the PQRI program is set at 1% of allowable Medicare fees for services in the practice. Other changes in Medicare reimbursement include office-based primary care providers can receive incentive payments of a 10% bonus for Medicare patients. General surgeons practicing in health professional shortage areas will receive a 10% bonus for major procedures they perform on Medicare patients. And there are new limits on reimbursement for MRI and CT scans conducted in physician practices. Reimbursement for Medicaid patients will also be improved. Family practitioners, internists, and pediatricians will be paid at Medicare rates for services they provide to Medicaid patients in 2013 and 2014. And there are important new implications in the area of compliance. For instance, physicians referring patients to CT or MRI facilities which they own, or to other in-office ancillary services, must disclose their ownership and give patients a list of alternative suppliers. Physicians are prohibited from new ownership or investment in any hospital as of December 31st, 2010. And the Health and Human Services Department must have a self-disclosure protocol for Stark violations. There are also several provisions relating to compliance with billing rules and regulations. Claims that are submitted to Medicare for services deemed to be violating the anti-kickback statute will be considered false claims. This means the government can seek up to 3 times the value of the claim in repayment. Claims for services to Medicare and Medicaid patients must be submitted within 1 calendar year of the date of service. And overpayments from Medicare or Medicaid must be returned within 60 days after the overpayment is identified. And regulations may be issued requiring new provider applicants to Medicare or Medicaid to have compliance programs in place. Right now, there's no requirement for physician providers to have a compliance program. It is possible when these regulations are issued that medical groups adding new providers who will be providing services to Medicare or Medicaid patients may also be required to have a formal compliance program as part of this new requirement. And there are other important implications for medical practices. All physicians billing Medicare will be required to submit CPT code modifiers for services identified as quality performance measures by CMS. Submissions for services in 2014 will determine payment levels to physicians in 2015. CMS is also establishing pilot programs to test bundling of payments for episodes of care. Services to be bundled this way may include physician services, hospital services, and post-acute services for up to 30 days following discharge. CMS would make a single payment for each episode of care, and those providers participating in the care will have to figure out how to split up the payment. There are also new regulations governing accountable care organizations. Provider groups such as physicians or hospitals or insurance companies can form accountable care organizations to improve quality and reduce costs. There are 33 quality measures ACO must address, including coordination of care, patient safety, preventive health care services, improved care for at-risk populations, and patient and caregiver experience. There are already over 150 ACOs recognized by CMS, and the portion of the population covered by ACOs is increasing rapidly as insurance companies begin sponsoring ACOs. Today, there are as many as 31 million people covered by an ACO. Providers participating in ACO receive payment at Medicare rates, and the organization can earn incentive payments for improving quality and reducing costs. But documenting and monitoring care requires sophisticated information systems. This map shows the accountable care organizations approved by CMS across the country in 2012. As you can see, there is a heavy concentration in the Northeast, the Upper Midwest, Florida, Texas, and California. The Affordable Care Act also modified the PQRI incentive program. For 2011, incentive payments were 1% of Medicare allowable charges as a bonus for reporting on quality initiatives. For 2012 through 2014, the bonus is 0.5% of Medicare allowable charges. Submission of this information may be made via claims data or through participation in a maintenance of certification program. And there are still more provisions of the Affordable Care Act. There are many other provisions affecting other healthcare providers, such as home health care and long-term care facilities. There are other provisions covering insurance companies and Medicare Advantage plans. And there are many provisions subject to regulations to be issued by the Health and Human Services Department. It is an open question whether these regulations will be issued timely. In summary, the laws and regulations implementing the Affordable Care Act will affect almost every citizen and legal resident, every payer source and organization, every provider organization, and all state and federal government activity related to healthcare services. But there are many things the Affordable Care Act doesn't do. It doesn't replace employer-based or individual health care insurance mechanisms. It doesn't fundamentally change Medicare or Medicaid. And it doesn't alter or preempt state regulation of healthcare professions or healthcare institutions. Will it work? Only time will tell. There are many excellent online resources to find out more about the provisions of the Affordable Care Act, including the timelines, the individual and business mandates, and the requirements on payers. Here's a partial list. This has been part 3 of our presentation on the implications of the Patient Protection and Affordable Care Act for medical practices. If you missed any of parts 1 and 2, please check them out on our website, foxgrp.com. Thanks. The Fox Group, providing excellence in consulting and implementation since 1989.